Actually, I will be talking about it in like 3 hours from now, I think. So it'll be today. And yeah, it's like a major issue actually, because as we just figured out, 1 in 6 patients that would actually be eligible for IVT, they are under DOAC, and the recent guidelines in the US and in Europe, they actually suggest not to treat those patients, given they have a last intake within 48 hours before stroke onset. And so that's actually recommending those patients to not treat them. And we started in Bern actually looking at our patients when they came earlier, like with an intake after 12 or like 24 hours. Just to see whether it is safe that those patients can be treated given like a severe deficit, like aphasia or hemiparesis. And that's what we're actually presenting here, like our first results. And like the guidelines currently, there is not sort of a change because they still recommend not to give TPA in those patients. But we hope we believe that there will be a change in the future actually. Like when the first results came out, like 3 years from now, that it could be safe to give TPA in those patients with recent DOAC intake, we actually stepwise liberated our own institutional guidelines, like saying, okay, you start treating patients depending on the DOAC activity levels, and we had like different cutoffs, and then we actually stepwise increased our approach to treat those patients, and this led like to this study, because of course as there still are the guidelines, we could not make everyone in the hospital treat those patients, so there were like more open approaches, I would say, or like more proactive approaches to treat those patients, and there were like the more conservative ones. And this means we could actually study in our own patient cohort, or like actually compare patients with recent intake of a DOAC that get thrombolysis versus those patients that did not get thrombolysis. And like the results that we actually figured out, we could include 100 patients, which is quite a lot for like IVT in DOAC patients. And we could find out that there are no safety concerns, at least in like our patient cohort. Like we did not observe any severe intracerebral hemorrhage. And we found out that, or we could see that our patients actually did have a better outcome when they were treated with IVT, which of course needs to be shown in an RCT, but at least it's like the first data suggesting that it could be beneficial in those patients. I think it should be an option in those patients, or at least we do it like in those patients when they come in an early time window where they have where they follow like the normal guidelines, given IVT, and we believe, or like I believe, that the intake of, or the recent intake of a DOAC should not be a contraindication, because like as we saw, or we did not observe any safety concerns, so it's just like depending on the severity of the symptoms. So if there are severe symptoms, I believe it should be done, and those patients should be treated.